Hello, everyone, and welcome to Frontier Nursing University's celebration of National Nurse Practitioner Week. This session will be presented by Dr. Carla Bray. Dr. Bray, at the age of 19 in 1995, became an LPN. She graduated from Northeast Mississippi Community College with an associate degree in 2002. And from the University of North Alabama with a BSN in 2008. In 2009, she graduated with her Master's in Nursing from University of Alabama in Birmingham and is a board-certified FNP with American Association of Nurse Practitioners. She's been an emergency room nurse practitioner and hospitalist since she became certified. She graduated from the Frontier Nursing University Doctor of Nursing Practice program in 2019 and received the DNP Project Exemplar Award. She strives to provide quality care using best practices for each of the patients she encounters. Dr. Bray.
Hi. Hello, good evening. My name is Dr. Carla Bray, and again, thank you so much for the invitation to present during Frontier Nursing University's virtual event for Nurse Practitioner Week. I am honored to be able to share with you how a team-based approach can save lives. I'm a hospitalist nurse practitioner, and I know firsthand that it takes teamwork and collaboration to have successful patient outcomes and provide quality patient care. Even if you work in or plan to work in a clinic setting, teamwork and collaboration are necessary. I would like to talk to you about how teamwork and standardization of care improve timely sepsis care in the rural emergency department in the hospital that I'm employed. At this time, as some of you may know, the Surviving Sepsis campaign 3-hour and 6-hour bundles are being used, and those components are required to report for core measures. We implemented the 2018 updated Surviving Sepsis campaign 1-hour bundle, and there is no way that this could have been successful without teamwork. The key takeaways are for you to learn effective strategies to implement best practices for timely sepsis care. Even if you are not employed in a hospital setting, it is important to know what sepsis is and how to recognize it early. As nurse practitioners, we look at best practice guidelines daily. So even if you are in a clinic setting, you may be the first person that this patient encounters. So you could recognize it early and get them to the emergency department before severe sepsis starts. I also want to look at the effects of standardizing processes that will help empower the team and the patients. I will show you how teamwork helped to improve sepsis care during this project. Lastly, I will talk about a multidisciplinary approach for improving timely sepsis care. I will discuss my sepsis care team and how we thought outside of the box to get these sepsis patients treated within 1 hour. I want to stress that early recognition and timely treatment are the keys to surviving sepsis. Sepsis is deadly when it is not recognized and treated in a timely manner, and mortality increases 8% with each hour that treatment is delayed. 270,000 sepsis deaths are reported each year in America, and it is the #1 cost of hospitalization in the United States, with $27 billion spent each year. Thankfully, there is guidance for us in the treatment of sepsis. Evidence-based guidelines with proof of effectiveness. Delayed treatment leads to increased length of stay, hospital readmissions, and poor patient outcomes. The evidence-based guideline recommends that weight-based fluid resuscitation and antibiotics be started within 1 hour. A decrease in mortality has been shown when guidelines and care bundles are used, and the use of nurse-driven care promotes timely care in the emergency department. Timeliness is one of the 6 aims for improvement, and it defines the difference between good health care and the health care that patients actually receive. We must recognize that a patient is at risk for sepsis early so that we can get treatment started within 1 hour. One person nor one discipline can improve timely care on their own. It definitely takes teamwork. Now we will get into what led to this quality project. Charts from 20 sepsis patients were reviewed and several major gaps in care were found. 70% were not recognized in triage, 80% did not receive the correct amount of fluids, 55% did not receive antibiotics within 1 hour, and 80% of the patients that continued to be hypotensive after fluid resuscitation were not given vasopressors. And I want to mention again that mortality increases 8% with each hour that treatment is delayed, so something had to change. With the findings during the chart review, we established an aim for this project to improve timely sepsis care to 75% in a rural emergency department within 90 days. So this project was conducted at Tippah County Hospital Emergency Department located in Northeast Mississippi. 744 emergency department patients were encountered during this rapid cycle quality improvement project. 4 plan, do, study, act cycles were completed in 90 days, and we had a multidisciplinary care team that consisted of nurses, nurse practitioners, lab, pharmacy, and IT. There were 4 main areas of focus during the 4 PDSA cycles. They were team engagement, patient engagement, sepsis screening, and the use of a sepsis checklist. Each patient encountered in the emergency department would have sepsis screening provided in triage. When a patient met sepsis criteria in triage, they would receive participatory patient education on sepsis with teachback of 4 main points. The nurse would start a sepsis checklist to ensure that appropriate orders were being started. And then the nurse would use a standardized patient handoff tool for all patients that were transferred out of the emergency department. So that everyone knows the criteria that makes someone positive for sepsis, they must have a chief complaint that indicates a new infection. So examples could be cough, dysuria, abdominal pain, swollen rash, a leg that is swollen. They also must meet 2 of the following criteria. Their temp must be less than 96.8 or greater than 100.4, so hypo or hyperthermia, tachycardia, tachypnea, hypotension, and altered mental status. Now I want to give a little bit more detail on the interventions that were used during this project. We started with the sepsis screening tool, as I had mentioned, and we had the sepsis risk criteria, which included the vital signs and the chief complaint. And then initially, the screening tool also included the severe sepsis criteria, which is known after the lab's result. Because of the time-intensive nature of the tool and the 1-hour window that we were trying to achieve, we simplified the screening to only include the sepsis risk criteria so we could get that information in triage. After simplifying the tool, compliance improved, but we were still not meeting the goal of antibiotics within 1 hour of arrival. This is when we started Power Hour. When a patient screens positive in triage, we call a code sepsis. All frontline staff report to the patient's room and start immediate treatment. They get their IV, they get their labs drawn, their vital signs. So this includes the lab, radiology, provider, and the nurse. By the 4th PDSA cycle, the sepsis screening was incorporated into the electronic health record to flag as sepsis for a positive risk. So the provider and the nurse would get an alert from the computer system. This is the Surviving Sepsis Campaign 1-hour bundle and is the evidence-based guideline for sepsis. Before we get started on how we incorporated the guidelines into practice, I want to talk about what the 1-hour bundle is. So it is recommended that the lactate be measured, that the patient obtain blood cultures before getting antibiotics, that broad spectrum antibiotics be started within 1 hour, and that we begin rapid administration of 30 milliliters per kilogram of fluids for any patient that is hypotensive or with a lactate of 2 or greater. Also, vasopressors are recommended for patients that are hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of 65 or greater. So initially at the beginning of the project, the nurse would use a sepsis checklist that was intended to be nurse-driven orders. We continue to have non-compliance with the administering antibiotics. So for the second cycle, we added antibiotic selection to the checklist. The checklist we found was being used as an additional place to document care instead of nurse-driven orders as it was intended to be. So we changed this to the emergency department sepsis order set. The antibiotic selection was based on chief complaint, and we felt the words order set would help the team to use it as just that. When a patient screened positive in triage, the nurse would initiate the order set. The order set was then built into the electronic health record, and by the fourth cycle, when the screening and triage would flag a sepsis risk, this order set would automatically reflex. After the patient flag set for sepsis risk, the patient was provided with an education tool. The nurse would go over the education tool and then ask the patient 4 questions. What body temperature should be reported? Ways to prevent sepsis? What is sepsis? And besides fever, what other symptoms should be reported? The nurse would then document that patient's score in the medical record. Educational posters were placed in the waiting room, in the triage area, and in the patient's treatment rooms. So this allowed for, even if a patient wasn't there with these complaints, this improved community awareness. The providers and nurses were also educated with posters in the documentation area. By the 4th cycle, the education was incorporated into the electronic health record to print with all discharges, even patients without a diagnosis of sepsis, to improve community awareness. To improve team communication and engagement, we started using a standardized patient handoff tool for any patient that transferred out of the department. We started with the situation, background, assessment, and recommendation, better known as the SBAR. But as you can see in this picture, it is a bit lengthy. And I want to point out that if you see something not working and you just don't know how to fix it, talk to your team. They're the ones doing it. They can tell you exactly what's wrong and how to fix it. After all, it does take teamwork to provide quality care. We simplified this to include only pertinent information regarding critical areas. And we were still having problems with compliance because of the time-intensive nature of completing it. So we changed it to the sepsis transfer record. And we only included the sepsis information that would need to be transferred to the team that would be taking over care when they transferred out of the department. So would that either be the medical floor or tertiary care facilities for higher level of care. By the 4th cycle, this too was incorporated into the electronic health record to print with transfer documents. So this also helped as a reminder when it printed out, the nurses would remember to use this standardized patient handoff tool. After the 8-week implementation, the aim was met with a mean value of 83%. Sepsis screening was at 100%, and team and patient engagement exceeded goal. So 83% of our patients received appropriate sepsis care with no increase in the number of patients that were transferred out of the facility due to sepsis. This run chart represents weekly data collection of timely care provided to patients screening positive for sepsis risk. The goal was exceeded after power hour for notification of sepsis was implemented. And this run chart represents the improvement in team engagement with the use of the sepsis transfer record. Goal was exceeded after incorporating the tool into the electronic health record to print with transfers out of the department. This is a very good example of how teamwork improves quality care. After it became standard of care to provide sepsis information, included interventions that have been completed in the emergency department and interventions that still needed to be completed, appropriate and timely care improved. And this chart represents the increase in patients being screened for sepsis using the sepsis screening tool. After simplifying the tool, compliance exceeded goal and was added to the electronic health record for sustainability. And this last run chart represents the increase in appropriate sepsis care. So when we're talking about timely sepsis care, we're talking about the 1 hour window. And then appropriate sepsis care is all of the care that is recommended on that 1 hour bundle. So you can see the increase after starting the emergency department sepsis order set. The turning point for this project was the implementation of Power Hour for all positive screens. Other significant interventions were the incorporation of the tools into the electronic health record and reflex ordering with all positive screens. So again, 83% of our patients with sepsis received appropriate care within 1 hour, and we started at 30%. After the first PDSA cycle, the tools had to be simplified due to the time-intensive nature of the original tools. So with the balance of significant details and simplicity, compliance with the tools improved. With the addition of Power Hour for code sepsis, nurse-initiated orders led to timely sepsis care. The interventions that were used during this project were patient-centered, they were nurse-driven, and they were quality care-oriented. We've also seen organizational benefits with this new process. There has been improved time management for providers, a reduced cost to the organization related to delayed treatment of sepsis, and we have had successful patient outcomes. In conclusion, our timely sepsis care improved to 83%, and all tools are now incorporated into the electronic health record for sustainability. And they were added to areas of the documentation that was already being completed, so it didn't add extra work for the nurses. The reflex orders are automatically added when the patient meets sepsis criteria in triage, and Power Hour for all positive screens improved timely sepsis care. The next step for this project is to educate the EMS department to begin early recognition and a standardized treatment plan for patients en route to the emergency department. So as you can see, the multidisciplinary team working together improved patient care. Power Hour is a team-based approach to timely care, and it has saved lives. Our mortality due to sepsis has decreased by 67%. And when the code is called, each team member is crucial. The pharmacy plays a role in antibiotic selection and making sure that the antibiotics on the order set are always available in the emergency department. Lab is involved by making sure they collect and report the results of labs in a timely manner. Radiology ensures that X-rays or CTs are completed timely to identify the source of infection. Nurses make sure to triage timely and to initiate nurse-directed orders for early recognition and treatment of sepsis. The ER providers ensure additional treatments outside of the order set are started, and that patient's disposition is determined early to prevent further complications due to sepsis. So as you can see, teamwork saves lives. Thank you for joining this presentation, and I hope you see the impact that teamwork can have. Good night.